All right, let's jump right into today's explainer, where we are going to unpack one of the absolute most critical documents in all of medical practice. We're looking at the anatomy of the comprehensive history and physical examination, and specifically we're going to focus on mastering the chief complaint and the history of present illness. Now, it is incredibly easy to look at the H&P as just administrative paperwork, right? Just another bureaucratic hurdle to clear before you get to the actual medicine. But honestly, that is a dangerous misconception. The comprehensive H&P is the fundamental baseline document that dictates the entire course of a patient's medical management. A poorly constructed H&P can literally lead to inadequate patient care. So we're going to break down how to get it exactly right.
Here is our anatomical breakdown for today. Number 1, the comprehensive H&P foundation. Number 2, capturing the chief complaint. Number 3, building the HPI narrative. Number 4, 8 essential CMS elements. Number 5, tools for HPI documentation. And finally, number 6, pertinent positives and negatives.
First up, Section 1, the comprehensive H&P foundation, the baseline of care.
So the comprehensive H&P is typically obtained when a provider sees a patient for the very first time in a general medical setting or when a patient is being admitted to the hospital. You really need to think of it as the primary baseline document. This record establishes the foundational blueprint for all subsequent clinical management. Think about it. Multiple providers, from consulting specialists to nurses, are going to read this document and use it to guide their treatment plans. Because of that domino effect, failing to take an adequate history, failing to perform a detailed physical exam, or simply failing to document your findings adequately can directly lead to inadequate care of the patient. The stakes here are high. It's not just about compliance, it is absolutely crucial for patient safety.
Moving right along to Section 2, capturing the chief complaint, the front door.
Okay, look. There is a massive difference between capturing a vague administrative reason for a visit versus capturing true clinical intent. Bad documentation relies on those incredibly vague terms, like writing reason for visit checkup or putting down no problems for a patient presenting to establish care. Good documentation, on the other hand, is specific and subjective. Something like, I have had a sharp pain in my stomach since yesterday. You absolutely must capture the specific, current problem for which the patient is actually seeking care. Vague terms are a disservice because they give subsequent providers absolutely no context for why your medical decision-making process unfolded the way it did.
So, the golden rule here? The chief complaint is best stated in the patient's own words. And to prove that you're capturing their subjective experience without applying your own preliminary diagnostic bias to it, you should identify those words using quotation marks. If a patient says their heart feels like it's fluttering, quote exactly that. Don't immediately translate it to palpitations in the chief complaint. Why? Because that clinical translation belongs in your medical assessment, not in the patient's initial subjective complaint.
Now, I know what you might be thinking. The reality of modern medical practice is that electronic medical records sometimes force us into predefined boxes. In many EMRs, you might actually be forced to select the chief complaint from a drop-down list, like clicking abdominal pain, rather than typing out a free text quote. But listen, even when the system requires this rigid input, as a clinician, it is still your responsibility to capture the subjective intent accurately within the history section of your note. Technology should never, ever erase the patient's unique voice from the clinical record.
All right, Section 3, building the HPI narrative, the story.
The history of present illness, or HPI, is literally exactly that, a chronological description of the development of the patient's present illness. You want to construct a seamless step-by-step narrative. You start at step 1 with the very first sign or symptom the patient experienced related to this problem. Then, in step 2, you track the chronological development. Did it get worse? Did the pain migrate? Did they try taking over-the-counter medications? Finally, step 3 brings us right up to the current encounter. Why today? Why now? Following these steps ensures anyone reading your note can perfectly track the evolution of the disease process from start to finish.
Next up, Section 4, 8 essential CMS elements, the rigorous standard.
These are the 8 essential elements recognized by the 1995 and 1997 CMS documentation guidelines that dictate exactly what needs to be included to have a robust, fully compliant HPI. You need to elicit location and quality. So where exactly is the problem, and is the pain sharp, dull, or maybe aching? Next, look at severity and duration. Have them rate the pain on a scale of 1 to 10, and find out how long this has actually been happening. Then you need timing and context. Is it a constant pain or intermittent, and what were they doing when it first started?
Finally, capture modifying factors and associated signs and symptoms. What makes it better or worse, and what else is going on? Eliciting and grouping these details ensures your documentation holds up to both clinical and administrative scrutiny every single time.
Which brings us to Section 5, Tools for HPI Documentation, the Tool Belt.
Now, to avoid missing any of those CMS elements in the middle of a chaotic, busy clinic, clinicians heavily rely on clinical mnemonics. A super popular one you probably know is PQRST, which stands for Palliative, Quality, Region, Severity, and Timing. It's a fantastic tool and very quick for pain complaints. Alternatively, there's QFOLR-IDA, which offers a much more exhaustive framework. That one covers quality, frequency, location, onset, radiation, intensity, duration, alleviating factors, and associated signs. It's a mouthful for sure, but whichever framework you choose, utilizing a mnemonic ensures you systematically elicit the necessary info during the patient interview, guaranteeing no critical elements are ever missed when you sit down to document.
And finally, Section 6, Pertinent Positives and Negatives, the Nuance.
You see, in medical documentation, what isn't there is often just as important as what is there. Pertinent positives are the symptoms present that actively support a specific diagnosis. Pertinent negatives, however, are the symptoms that are notably absent, which helps rule out a diagnosis or make it highly unlikely. Documenting both of these elements builds a crystal clear pattern recognition for anyone reading your note. It essentially proves that you are actively narrowing down your differential diagnosis based on the actual clinical presentation, rather than just blindly writing down whatever the patient says.
Let's ground this in clinical reality using a classic example. Imagine a 22-year-old young man presents with a low-grade fever and right lower quadrant abdominal pain. Naturally, acute appendicitis is going to be high on your differential diagnosis. Now, patients with appendicitis typically present with anorexia, meaning a complete loss of appetite. If you document that he has anorexia, that is a pertinent positive supporting appendicitis. But if that same young man asks you how soon he can order a burger because he's absolutely starving, well, the absence of anorexia is a massive pertinent negative. While it doesn't 100% rule out appendicitis, it certainly makes it a lot less likely, and documenting that pertinent negative is crucial to painting the full, accurate clinical picture.
So, when you look back at your own recent documentation, I want you to consider whether it accurately captures the patient's own words. Think about whether it chronologically maps out those CMS elements and utilizes pertinent positives and negatives to clearly demonstrate your clinical reasoning. Remember, the comprehensive H&P is your opportunity to set the trajectory of care for that patient.
So ask yourself, does your H&P truly tell the whole story? Make sure your documentation rises to the occasion. And please like, share, subscribe to Decode Healthcare with Harshal.